everybody. Welcome back to another episode of Honestly Bilal. I'm your host, Bilal Ahmed, and I'm a fourth-year medical student at the University of Toledo. And this is Honestly Bilal, the show for the aspiring ophthalmologist, where I sit down and talk to medical students interested in ophthalmology, residents training in ophthalmology, and current ophthalmologists in the field today. Today, my guest is Dr. Michael Kloufis. Dr. Kloufis is an assistant professor of ophthalmology at Thomas Jefferson University's Wills Eye Hospital. He got his medical degree from Cornell, where he also did his residency in ophthalmology after getting his degree. And then followed by that, he moved from New York City to Los Angeles and did his fellowship in vitreoretinal surgery at the UCLA Jules Stein Eye Institute. And he's been a member of the American Academy of Ophthalmology, the American Society of Retina Specialists. And on August 25th, he's being inducted into the Retina Society. He is a manuscript reviewer for retinal cases and brief reports for Retina. And he's also on the editorial board of New Retina MD. And he's the retina chief for iTube.net. So Dr. Kloufis, welcome. Thanks for joining me. Awesome way to connect with you via Instagram. So thanks for joining me, number one, and it's a pleasure to be with you.
Thanks, Bilal. That was a very kind introduction, and great to be here. I really feel like I'm not too far from medical school, so it'd be great to be a part of this process and just contribute to all the mentorship that you're starting here.
Yeah, absolutely. And I can't wait to talk about your story a little bit and see your journey and how that has transpired to where you are today. So let's talk about ophthalmology and retina. So what got you interested in ophthalmology? When did you find out, hey, I kind of want to do this? And after that, where did you find out about retina and vitreoretinal surgery?
Yeah, it's funny you asked that question because sometimes I talk to my patients, and I was really close with my grandmother, and she had bad diabetes and actually diabetic retinopathy, and I came from a medical family. My father had 5 brothers and 1 sister, and every single one are physicians, none ophthalmologists, and his sister is a dentist, and his father was a doctor. And so I know sometimes in medical school, people may talk medicine as sort of a calling or a profession that runs in families. And so I definitely grew up as the first grandchild of this very large family, thinking that I would go into medicine. And I think it's an amazing career. My parents always said to me, like, you don't want to go into finance. You don't want to do anything else. Doctor is the most prestigious thing. And, this is just such a special gift that you can give people. But I didn't think I would be going into ophthalmology. And the story about my grandmother, I remember, she got cataract surgery, I think focal laser with a retinal specialist. I know what these things are now, but I never even thought about those or thought about ophthalmology until I was in medical school. And they had an ophthalmology interest group. And I remember there was an ophthalmologist who was the residency program director at that time, Chris Starr.
Mm-hmm.
They showed us how to use a direct ophthalmoscope. And at the very end, he says, we come and show you guys how to use the direct ophthalmoscope, but we don't really use this in our jobs every day.
Yeah.
Here's my card. If you're interested, let's chat sometime and we can get you involved. And he just seemed very happy and passionate about everything he did. And so I went to a couple more of those ophthalmology interest group sections and got to know him as a friend and a mentor, and really saw that the ophthalmology department there were quite happy with their jobs. I think the younger generation, millennials and everyone, we are a little bit more conscious of work-life balance. And my father's, I think 67 now, and he's going into nursing homes treating COVID patients. And when I was growing up, he was like working all the time, rounding in hospitals on the weekend and running his own practice. And, he did so many important things for the community, but I think there was a little sacrifice for family. I mean, I saw him every day and stuff, but he worked really, really hard, and he still does work really hard. And, as I got to Cornell Medical School, went through my training, I saw the ophthalmologist and I saw a little bit more balance there.
Sure.
And then the other thing is, I liked surgery. I like using my hands, but, general surgery, standing up for 8 hours and, rounding at 4 a.m., it just didn't seem like a great fit for me long-term. So I thought, well, let me look at some of these specialties where there's a mix, such as ENT, ophthalmology, where you do a little bit of surgery, but you also have the clinic patients. And, some of the other traditional things people talk about appeal to me, treating patients of all ages. We do treat a lot of elderly patients, and, like I just mentioned, I was close to my grandmother. And so, when I see some of my elderly patients now, I try to treat them like a family member, and it reminds me of her. So, I feel connected in that way.
Mm,
Um, but yeah, and the ophthalmology department had just gone under some changes when I was a medical student there. They had recruited Dr. Don D'Amico from Mass Pioneer, who was a pretty well-known retina surgeon. And so he recruited a bunch of young faculty among Chris Starr, Paul Chan, Salar Kish, and all these people ended up being mentors to me, especially because I went on to my ophthalmology residency there as well.
sure. Yeah. What I like that you said is something that, I think a lot of the physicians I look up to really talk about is, using, thinking about, treating patients like family. And I've always felt like that's the best advice I've ever gotten. Just like think about it as if it's your own grandmother or your mom or your sister, your brother, your cousin, your friend. So I think that's really, really useful. And it seems like it's been a big part of the motivation for you to go into where you are today. And I think it's really cool.
Yeah, I mean, even as a med student, being involved in whatever kind of medical service, whether it's general surgery, I find if you professional, respectful of your patients, and also say you will do your best to treat them. No one really expects perfection. I mean, you can get a difficult patient who wants reassurance, maybe doesn't want to hear about complications, but
Mm,
if you tell them you are going to do your best, even if they have a serious or difficult to treat condition, I find that over time that really sits well with them, no matter the outcome. And so I think there's some navigation with the doctor-patient relationship, but reassuring them that you will do everything possible is very reassuring to many patients.
absolutely. Setting those realistic expectations and then doing your best. That sounds like something I think we should all keep in mind. And I'll try to keep in mind from you as I go forward and keep that little nugget of information. So it's a cool way of doing things like this. So get to find out more about other people's perspectives. So another perspective I want to talk to you about is, your background right now. I see awesome, the Boyle's Eye building is there, and clearly it's not a real background. Spoiler alert for everybody who's thinking it is, but it's obviously it's a very well known hospital. It's one of the most prestigious and esteemed places to not only train but also to get patient care and to give people a lot of the first line sort of the treatments are out there that are really looked at and very influential. So talk about how did you end up going from Los Angeles to Philadelphia and how did you end up at Wills?
Yeah, it's a good question. I'm not from California, though I did really enjoy my time out there, and our daughter was born out there, and we lived in Santa Monica, and West LA is beautiful, and the sort of the California lifestyle was great. Um, so I would say one really big diverging point, I think this happens a lot in ophthalmology training programs, whether it's residency or fellowship, is the amount of supervision and how much autonomy you'll have.
Mm,
And there's a lot of different schools of thought. And so I would say where I did my residency was very supervised.
mm,
Always an attending present for every single laser, surgery, et cetera. Um, on the flip side, there are residency programs where, there is a lot more autonomy. You might be doing intravitreal injections on your own
mm,
after you have some training, or retinal lasers even on your own for diabetic retinopathy, such as PRP. Uh, but my residency in particular, it was felt that the best way to learn was to have a lot of supervision, a lot of hand holding. And when I was looking at retina fellowships, I knew I wanted to have a little bit more autonomy to see that side. Uh,
mm,
and I was warned too that perhaps too much autonomy is not good, because if you don't learn how to do something the right way, that can make it harder and longer for you to learn something. So for instance, you see one or two procedures and then you go do one on your own. But if you're still not totally proficient and you make mistakes, you could do 5 more of those procedures and carry that mistake forward. And so that is the argument for having a lot of supervision. On the flip side, if at some point you will graduate from your training and go out and be an attending, and you will be on your own.
mm,
And so you won't always have that person standing there. So some people will say, well, you need to have some autonomy and responsibility to be able to do things on your own to prepare you for what is coming very soon, wherever you decide to practice. Uh, so I know we went a little roundabout, but I knew Jules Stein, UCLA, had a mixture of good supervision, good surgeons, many different surgeons, but it also had the county hospital system.
Sure.
which is where you are really the responsible retina attending sort of on call. And so for me personally, being held accountable on things and seeing the other side of this type of training with a mix was really helpful, and I think really prepared me for my first job. Uh, when I was looking at jobs, the way I ended up back at Wills, I had interviewed at the Wills Fellowship, and Arnon Sivalingam, who's the program director, he had called me when the job search was happening, and he said, you know, we have an opportunity for you.
Mm.
And my other big job I was considering was returning back to Cornell and joining the faculty there.
Okay.
And I loved the people there. They were great retina specialists. And I actually really wanted to go back to Cornell. But in the end, you know, you're threading the needle, and I mean, the Wills job is very hard to turn down, number one. And then number two, my wife really didn't want to move back to New York City. And so, you know, we thread the needle and took the job with the Mid-Atlantic Retina and Wills Eye Hospital, which has been a great experience for me so far.
Very cool. And part of that job is what we talked about a little before we got on here, was that you really oversee a lot of the fellows in the fellowship. And you know, I think one thing that we were wondering, or you know, something you and I thought about would be a cool thing to talk about, is that, you know, there are some residencies where you really have this you know, a large residency, and then also these really access to fellows who are getting a lot of experience in their fellowship. So I know part of the experience that you talked about to me about at Wills is that the residents at Wills Eye Hospital do interact a lot with the fellows, especially on the retina service. So talk about how that that mentorship philosophy goes at Wills, and talk about even maybe in your training, how learning as a resident from fellows, or being a teacher as a fellow is a pretty important aspect of training.
Yeah, it's a great question. I think every sort of ophthalmology center will be a little bit different. So you kind of got to figure out how to navigate it the best, to interact with the attendings, you know, learn from the fellows so you can interact with the attendings appropriately and somehow be involved, you know, in the retina clinics. Jules Stein and Wills Eye, you know, they're very fellow-centric places. You know, 2 retina fellows per year at Jules Stein, 3 retina fellows per year at Wills. And so a lot of retina fellowship training is surgery. And so, you know, the retina fellows want to do a lot of the surgery, but the residents can still be involved. But, you know, the attendings are mostly interacting with the fellows, and then they sort of have their clinic too at Wills, sort of fellows clinic, where the fellows are really in charge of running that along with attending supervision. And so, you know, from a resident standpoint, the fellow can be very helpful to sort of mentor and guide you in how it would be best to be helpful during retina clinic, or be involved in the Wills fellow clinic as well, participating in lasers, intravitreal injections, which even general ophthalmologists are performing today,
Yeah.
And to be competent in some of these things. And my other piece of advice would be, you know, you never know what kind of practice environment you will be in. You could be a general ophthalmologist somewhere in a more rural area, and you may be performing intravitreal injections. So even if you're not interested in retina, it's always valuable to have some baseline experience with these procedures. So it would be great to learn how to do PRP, because their diabetes is rampant across the United States. It's great to learn how to do intravitreal injections and feel confident, because you may choose to do this in your practice for the service of your patients. And then the other side, of course, if you're interested in retina, it's a pretty competitive fellowship. There aren't like tons of training spots. And so I do think, because of the small NIC community, if you're really interested in retina, it's important to try to get involved with some of the attendings to help mentor and guide you. And sometimes working with the fellow to find the role for either the medical student or the resident can be very helpful in figuring out how the system works.
Got it. Yeah. And speaking of some retina stuff, we have a cool video that you shared with me that would love to just get you to talk through what's going on during the surgery. So anybody who's in the podcast audience, sorry, we're gonna have to defer you to the video source at some point if you'd like to see the YouTube part of it. But let's talk through this video. I'll screen share right now, and we can talk about it. And let's see. Let's just have you teach us about what's going on. Is that okay?
Yeah, sure. Great. So this was a gentleman. He came from about 3 hours away from Wills, and he had a intraocular foreign body in his eye. So you could actually see it on examination. So sometimes there can be a lot of blood in the eye or something like that. You can't see, and they'll get a CT scan, usually to verify it. But this one was, there was noted to be a fair amount of blood in the eye. A CT scan was performed, and there was noted to be a metallic, so a piece of metal in the eye, and he was fixing a fence on his farm. And so I was in the operating room that day, and he traveled down to Wills, and we performed a vitrectomy with removal of this intraocular foreign body with a forceps through an enlarged incision. Where the metal had impacted the eye, there was a small retinal break, and also in the posterior retina, there was a strike site. And because he came from far away, we lasered these areas, even though there wasn't a large retinal detachment, and placed a silicone oil bubble in the eye to make sure everything stayed in place. And I've been following his chart. I actually don't go up to that area, but two of my colleagues do in my group. And he's been doing well so far. And hopefully, as long as the retina stays attached, we'll remove the silicone oil. Because these things come from the outside world, infection risk is actually quite high. So we place them on oral antibiotics. But if you look at the video at the very end, we inject some intravitreal antibiotics in the eye to help prevent endophthalmitis or infection within the eye. And we slightly lower the dose because there was a silicone oil bubble in the eye, but we wanted to monitor for that. The other interesting thing was sometimes you have to, the exam preoperatively where the resident is involved or the fellows are involved trying to figure out what's going on can be very helpful. So he had a very small self-sealing corneal laceration, but also an iris transillumination defect. And the piece of metal was lodged anteriorly in the vitreous space. So you couldn't actually see it, but you could see it on CT scan imaging. But those clues from the initial examination can be very helpful.
Okay, so I'm gonna press play here, and then you can kind of walk us step through step. Okay.
Sure.
So.
You can see here we did a little peritomy superotemporally, and the patients had cataract surgery. We did the peritomy to make sure we could enlarge the incision, and here you can see the iris transillumination defect on retroillumination. Mm-hmm. And now we're doing the vitrectomy, removing the blood. You can see some blood in front of the retina here. We've placed some steroid to help visualize the vitreous, and then we're removing all the vitreous in the eye, and you can actually see the blood over here in the anterior vitreous base. And then as we remove this blood, we can see that there's a metallic foreign body. But we remove all the blood, and then I loosen this thing up because it's really lodged in there, but we have to remove it, otherwise it can cause some long-term complications in the eye once we've removed all the vitreous gel, because we obviously don't want this gel tugging. We only want to remove that little metal piece. And so I dislodge it right here, and I place it on the area where it struck the back of the eye. And now we enlarge this incision. That's why we created the conjunctival peritomy, so we can remove it. If it's not big enough, it will get stuck up in the vitreous space. Okay. And so we enlarge it nicely here, and then we take a pair of forceps. Actually using my left hand, which isn't dominant, but it just was easier in this case. And large pair of forceps here, and we just get that little piece of metal, gape the incision here so it doesn't get stuck up in that area, and it, little slow motion here, it just popped right out.
Yeah. Look at that little slow-mo effect.
Yeah, because it kind of popped out, which is good. You don't want to get stuck up in the eye.
Sure.
And we close that incision up, and this is Vicryl suture, just lasts a little bit longer. And I replaced my cannula, so I have a closed system there, that little orange thing. And you can see it also hit the back of the eye at some point here, so it caused a retinal break. So we laser that because the high risk of turning into a retinal detachment. And then we laser the area where it was lodged up there. And doing a little bit more laser here just to see everything out. And then we take the fluid out and we put air bubble in the eye now. Make sure everything's flat. Do a little bit more laser to the very edges so it all just scars down nicely. And I actually lasered also prophylactically under that larger incision because sometimes the remaining gel can tug. We close that thing up, and then we put a silicone oil bubble in the eye and closed everything up. And then at the very end here, we give some antibiotics to the top layer of the eye and also inject them into the eye. Not pictured, but we did do that at the end of the case. But so a pretty neat case. You know, they're not super common, but especially being at an eye hospital, you know, these often get referred in because we have a retina surgeon in OR every day, and great equipment, and keeps functioning into the night as well.
Yeah, no, I think it's so cool. I mean, just like to see the video, I just think it's cool to talk through the case and learn from what you're doing, because it's the step-by-step part of it is very evident. And I think that's a nice thing about, you know, look where we are today, like what we can do through Zoom and just doing things like this where you can talk me through something. And even though I'm just a medical student, I can understand for the most part the language of what you're talking about and what's going on through that visualization of the actual process. So I think I think like things like this are really exciting to see where this can go. And in terms of teaching and education, like this could be like this. It already is becoming a way of
Yeah.
teaching, but it may be a more permanent thing going forward for training purposes or fellowship purposes. So I don't know. That gets me kind of excited. I'm sure maybe it gets you excited too.
Yeah, I mean, you were talking about why people went into ophthalmology, and they usually have video recording systems, and looking in the OR when you're seeing someone operate,
Mhm.
some of the retina stuff's pretty cool, like
Oh
we just
yeah,
looked at right now, and that image quality is really good. But I can say, one really nice thing is to like even be the assistant in the beginning for an ophthalmic case, whether it's cataract surgery or retina surgery, because when you look through the scope, it's really just like a perfect image. And it's kind of like seeing like a great natural scene, like you go
yeah,
to like Machu Picchu or like
yeah,
Mount
yeah,
Kilimanjaro, and
for
looking through
sure.
there, like in the scope is almost like as exciting because of just how high resolution these things are.
Absolutely. I actually last 2 weeks ago, I'm on a away rotation right now at the University of Kentucky, and I got to see some stuff in the Retina OR. So got to see some Ingenuity stuff, and I was like, this is awesome. This is so cool. Come on, like this is not you can't beat this. If you're in an OR, I think any specialty and you saw the Ingenuity stuff, you'd be like, wait a minute, this is like really just different. And it's cool. I mean, it's just awesome because you can actually see everything as a student,
Yeah,
and you feel engaged because you're like, okay, I can actually for the most part see where every dimension of where we are right now, what space we're in, and I don't know, it's just that's the cool thing about the technology, like you're saying, and it's only evolving, so it's only going to get crazier from here and stuff like that. So, uh,
yeah,
I think
I agree. I mean, Ingenuity's so great because the surgeon is actually looking at the Ingenuity screen, so
mhm,
you are seeing the exact same image the surgeon is using in a system
right,
such as Ingenuity, as long as you're properly aligned with the
yeah,
screen.
yeah,
Whereas, the scope, which in my day, Ingenuity, when I first started training, didn't exist.
mhm,
You really had to be at the side scope to get the best image. But,
yeah,
there could be a screen in the room. But now Ingenuity, you're actually seeing what the surgeon's seeing. And, that's like I think better than a 1080p screen. It's, I think a LCD or OLED screen. So it's like
right.
a really nice screen.
It is. It is. It's very nice resolution, and you can wear 3D goggles, which is always kind of cool. Feel like you're at the movies again. So
Yeah.
that's pretty cool stuff. So, Dr. Kloufis, let's talk about August 25th. You're getting inducted into Retina Society. I mean, it's a huge honor. You're being inducted with multiple other people, including one of my mentors, Dr. Sridhar, who has his own podcast, the Retina Podcast, straight from the cutter's mouth. So, talk about what that means to you and being in the amongst some of the people who are well known in the field and that when you found out the news, like how did it feel, and just talk about that that whole process about to happen.
Yeah, yeah, no. I mean, I definitely am someone, and I think who's lucky to still be part of Wills and sort of be in this hybrid practice and still be involved in research and training, et cetera. And so I definitely was very eager to try to stay involved and active. And I think applying to the Retina Society was a nice next step to try to do that. You submit a research paper, they evaluate your resume, you get two sponsors. So I have to thank Dr. Stephen Schwartz of UCLA and Dr. Julia Holler for being my sponsors and supporting my application to the Retina Society. And, I wasn't sure I was going to get in, but, I have worked hard. And so I feel honored to be part of the Retina Society, and I hope it keeps motivating me to keep performing research, reviewing journal articles, being involved in any capacity. And so I'm also happy that many of my colleagues in my group, such as Dr. Sridhar, we're all joining together at the same time. And so I think we'll work together stronger as a team and go forward from there.
Awesome, awesome. That sounds so cool. And I know a large part of you've been involved with VBS, and again, like you mentioned, that you have friends in other institutions and stuff like that. So, talk about how like what has that process been like? You go through one of my previous guests, Dr. Luckenpaul, talked about it. How you go through training and you're going through a really hard process, and you become friends with some of the people along the way. So, have you how has that process been about making friends in the field who are in the same sort of niche as you, and like how do you value those friendships, and what do you really treasure about them?
Yeah, I think there's so many different capacities. You can be involved with colleagues, co-fellows, senior fellows, especially when there's fellow to fellow learning at any place you train at. And there's definitely a very strong bond between the fellows who are training at a place at the same time, because you're going through some of the same challenges, whether it's a tough work environment, tough cases, hard cases, long days, trying to do your best to learn retina surgery, which I think is hard for most people to learn, but takes practice. And then, while everyone's at the same place at the same time training, they know what you're going through to get to your final job. And then people go into different practice environments. I have friends who work in academics. I have friends who work in hybrid practices like myself. I have friends who are in straight private practice. I have a close colleague who works for a Medicare Advantage plan as the only retina specialist, which is super unique because it's not a fee-for-service model.
Sure.
Those common reasons you might text someone or your mentors from your training may be a very difficult case, and this is what I was thinking of doing. What do you think is the best idea? But there are also practice management issues, how you'll be compensated, staffing issues, clinic flow, all these different things. And there's so many of these online forums now, whether it's through Zoom, like we're talking now, or like WhatsApp. I have a bunch of different threads, and people will be asking questions, and it does help you stay connected, especially as these clinics get very busy and you're looking for a quick answer or a quick opinion, and to be on those forums can be very helpful. I think too, just having colleagues, some of the best, I think, research ideas come from collaboration. Your ideas are really stronger together, working together to really develop an idea and then participate in a research project. And I'll give you an example too. A medical student when I was at Cornell, Nico Yanuzzi, he went on to Bascom for his residency, and then he was a chief there, and now he's an attending down in Bascom. And we still keep in touch. We'll talk about cases, but I had a little instrument, a disposable forceps break off in the eye, and I was able to remove it. And I said, hey, have you seen this? And he's like, oh, I've seen a couple. So we talked, and then we said, let's put together a case series and evaluate how common this might be. And so having those connections can be very valuable and collegial, and also lead to good clinical research.
Dr. Kloufis, just want to thank you for taking the time to talk with me, share your wisdom, share your story, share your case. That was also really cool, and it's something I've never done on the show before, so it's cool to have that new twist of things, and just also learn. That's just a cool way to just learn something that I would love to see more of this kind of stuff, and we'll see down the road what resources are out there for this kind of learning. I know that you're the retina chief for iTube, and iTube has a lot of great videos like this, so hopefully then in my training at some point, I'll be watching more of your videos. So looking forward to that. And before we go, one interesting thing about you is that your parents are both Ukrainian and you speak some Ukrainian. So teach me one word in Ukrainian and then I will let you go.
Yeah, sure. Just to say hello, it's Dobre den.
Dobre den.
Yeah, so it's like dobre means good and den is day. So it's like good day.
Good day. All right, awesome. So I'm gonna dobre day, and I will try that from now on. See now.
There's a Ukrainian population in Ohio, so you might have some.
Okay, great.
Cleveland, though. I don't know about Toledo.
Yeah, I gotta drive out there then. All right, so I'm already connected to the Ukrainian community now. So there you go. It's crazy things, how things happen. So, Dr. Kloufis, thanks so much for joining me. Looking forward to hopefully meeting in the future someday in person. And until then, best of luck to you and everything. Stay safe, stay healthy, and we'll talk to you another time, hopefully.
Yeah, thanks so much for having me. Hope it's been helpful, and just reach out. I'm always available via email or Zoom.
All right, Dr. Kloufis, thanks so much for joining me. If you're out there and you like what I'm doing, honestly, Bilal, you're a medical student, maybe you're pre-med, maybe you're a resident, or anybody who's out there, feel free to shoot me a DM on Twitter at Bilal_1712 or on Instagram at honestlybilal, and we'll look forward to talk to you or just see what you like to hear on the next episode. So until then, thanks so much, and talk to you next time. Bye-bye.